Dr. Sterry, tell me about, please, a mid-face or a cheek case that again really stayed with you, a patient whose result taught you something about what the area of this face demands.
Uh, yeah, look, I think that in this zone, it's really all about getting a release of the zygomatic ligament, which sort of is a fibrous attachment of the soft tissues and basically the skin down to the elbow of the cheekbone right here. And you're not really able to get a nice lift in this zone unless you release that first, and then suddenly you get this big aha moment, and the whole cheek starts to elevate and lift for you, and it becomes free, and it becomes obvious that this is what we're trying to achieve. Um, in the operating room, we'll be moving things around and doing our dissection and working really hard to stay safe. And then we check once in a while to see if we're fully released. When you finally get the last bit of that ligament, because it's very ill defined, by the way, it's not like something you can see. It's not like like your Achilles tendon or something like that. It's very hard to distinguish. When you finally get that release, it's really a dramatic whoosh of the tissues, and it's the way I believe that you're able to make people look natural because you're sort of putting the architecture of the face back to where it was when they were much younger, and then you just stabilize it there. Uh, these procedures nowadays are far, in my opinion, they're far better and far more natural looking than they were 20 years
Wow. Okay. So you don't necessarily always see that final release. Honestly, of the interviews that I've done, this is the most I've heard about. You have to have a release before you can pull. And I really appreciate you educating us on that. So, but you just feel this release. It's kind of the skin moves or
Yeah. Yeah, there's no doubt. Most of us, and it's funny that no one else has mentioned it, most of us will put a couple of Alice clamps on the smaz tissue, and you sort of want to see how much you've advanced and are you getting what you want yet? Because you want it to move superiorly and laterally without effort. It should just glide. It should just sort of go where you want it to go. If you got to pull it tight, then that's wrong. It's not fully released. It literally just sort of flows superiorly and laterally off to over the cheekbone, and then okay, that's so much better. And when you're looking at the patient on the table, you can tell, wow, she looks great. And you compare the left cheek with the right cheek, and you can see the difference. And uh, you know, you make sure it's cosmetically pleased.
yeah, this is like truly, it's like sculpture.
But this part of it is actually, yeah. I don't usually use those esoteric ideas, but yeah, yeah, they kind of do.
Dr. Sterry holds a patent for a surgical retractor he designed himself and has been asked by fellow surgeons to author two textbook chapters on body contouring. Coming up, he's going to tell us what the mid-face actually requires to get a meaningful result and what most patients do not hear in a consultation. And at the very end, he's going to share something honest about one approach to this area that most surgeons don't say out loud. Dr. Sterry, welcome back to Beauty Seat.
Thanks so much.
The mid face, the cheeks, the nasolabial folds is it's where a lot of visible aging happens. On a scale of 1 to 10, how significant is mid face descent in the overall appearance of aging?
Oh, gee, it's hard to put it in terms of a scale of 1 to 10, but it's at least a 5 or 6, I think. As we age, we know that that the fatty tissues and the fullness that used to be up here in our right over our cheekbone, it sort of descends, which is what contributes to the encroachment and the deepening of the nasolabial fold. It also means that some of the fullness that was in our cheek, like the apple of the cheek, as it descends, it sort of becomes a jowl. So yeah, these are significant changes that happen. So putting things back up superiorly, and by the way, we also know that we lose bony tissue and we also lose some of the soft tissue as we age. So a little fat grafting is helpful, but as we advance and put things back where they sort of belong, my mother always told me put that where you find it, put that back where it belongs. You put it back up where it belongs, you enhance it maybe with some fat grafting, you get a very nice outcome, much more youthful.
A traditional mid-face lift, otherwise known as open surgery, which I'm hoping you can share a few more details of that. It has a known track record. On a scale of 1 to 10, how reliable are the long-term results of traditional open mid-face approaches?
Well, I think if you're in traditional open mid-face approaches, gee, that's a tough one. There are so many of them. There's the subperiosteal mid-face lift. There's so many different techniques. Um, I think I would divide it up a little bit differently. I'd talk about SMAS imbrication and SMASectomy, which is so the SMAS is the fibrofatty tissue, the connective tissues in in the cheek here, and we're all trying to find ways to advance it, put it back, as I say, where it belongs, to get it to stay there. So there are many people who will just put some stitches from the lower portion of the face up to a more fixed position and try to pull things up. And then they hope that they stay there after they close the skin. And you know what? Some of them don't look bad at all. Now, their longevity probably doesn't hold up as well. These are hard to get good studies on, by the way. Um, but sometimes if it's done well, they look pretty damn good. It's hard to argue with that. Um, the more 2026 version is where we actually go underneath those layers. We go sub-SMAT, we go like underneath that connective tissue in an area that is a little bit more treacherous. It's a little bit more murky because there's some soft tissues mixed in with some nerves that we don't want to injure. You got to be very careful. But when we release that zygomatic ligament, there's a couple of other ligaments, by the way, but that's the main one. And then we advance those tissues up and fix them in place. I think we're having, in my hands at least, I'm getting much more longevity and a much more natural look. Am I answering your question?
Yeah, it's hard to know, as a beauty seeker, when we're trying to understand, should I lean towards this new technique? Has it proven? Is it going to last? Well, this other technique, I'm hearing it lasts a long time. How do we know where to go?
Yeah. Look, the consumers are kind of stuck, right? Not knowing how much of this is spin and how much of it is marketing, et cetera. I can tell you that I tinkered around with just about just about every facelift technique that there is, and I choose to do the deep plane because I think my results are better and longer lasting. It is arduous. It takes in my hands it's 5 or 6 hours. It's very tedious, but I do it because I think the outcomes are better. I think the patients look more beautiful. I think I'm more proud of the work when I walk out of the operating room and when they come back in for post-operative photos, etc. It really makes me very happy. Each one of these folks is my own little, creation sort of, and I want them to look great. I want them to look like them. And I want it to hold up. I want them to tell their friends when their friends say, "Gosh, you look great. You're aging so, so gracefully. How do you do it?" I want them to give them my name. I want to be that person.
Exactly. And that's what we do. We talk and we share. Perfect. Many of the surgeons that I've interviewed, they've spoken about cadaver training, which totally, I'm totally into something like that. The ones that spend time in the anatomy lab, and they're, kind of testing how surgical techniques, could evolve. On a scale of 1 to 10, how important do you think that kind of training is for surgeons who want to push more into, I don't know, complex or newer, techniques?
I think that's an 11 out of 10. You know, Look, I finished training in 2001. Things have changed since then. And if you don't, if you're not moving, you're stagnant. And I really think that you've got to go back and continue to refine your skills and refresh, and learn new things. And I don't want to practice the first time on a live patient. So, the cadaver lab, as I don't mind telling you, it's not something that I relish. It's sometimes very disturbing, but I appreciate what that person, the cadaver, is offering me, and I try to make the most of it. Without those labs, I think I've been the best lab I'm aware of happens to be in St. Louis. I've been there, I think, 5 times. Um, I learned something new every single time, and just appreciate it. It's one thing when you see something on paper in a textbook or if you're watching a video, that's still only two-dimensional. Even a live video, right? It's still two-dimensional. When you are in the lab and you see, oh my gosh, look how close, when I do this technique, look how close I am to structure A, B, C, D. The last time I was down there, I realized just how close I was to the facial vein when I'm doing the submandibular gland. These labs are terrific. I think they're key. They're uber important. I can't say it enough.
I love that. So I'm a donor. I have a donor on my license. Does that mean I could end up be a donor for anything?
No, I think when you're a donor, you're an organ donor. I believe that's not donating your body. I think your family does that. I think when you're an organ donor, it means that if somebody needs a liver, they can use your liver if you're not with us anymore.
Oh, okay, great. Okay. I'm gonna have to dig into that a little bit more because I was just also learning about donating fat. That some surgeons are doing fat transfer with cadaver fat.
That's the newest thing. That's called alloclade. There's a couple products, but alloclade is the one that I'm more familiar with.
Oh, great. Are you doing that?
I've only used it one time actually, but I gotta tell you, it was great. It was really simple, so easy. Patients incredibly happy. Yeah, I could see using something like that again. Sure.
Could you just touch on that just quickly, just so, because this is so new, I would love to just get an explanation to the beauty seat community. What is it? Why would you use it?
So let's say let's say you are a very slim person and you want a little more booty. Um, we can't do a Brazilian butt lift on you. That's where we borrow fat from one area and we inject it into the buttock area because you don't have a donor site. There's no place to borrow it from. Or let's say um, you had liposuction and you had a problem and you got a little bit of groove or a dent and you just want to fix that. Now, the best way to do it is with fat, of course. So to have the ability to take something off the shelf and in a matter of minutes have it injected with almost no pain, no big ordeal, no anesthesia, big bang boom. It's a pretty great concept. Now, I thought it was kind of gross when I first heard it, but the truth is, I had to stop myself because I had my neck fused a few years ago, and they used banked bone to fuse my neck. How is this any different, really? Sure, you might argue it's a little bit more frivolous, right? Without fixing my neck, but um, it's still the same concept.
Perfect. Thank you. Great. I'm excited to dig deeper into that. Okay. Back to midface. If a patient is considering midface surgery, is there a question that they should be asking their surgeon, which when you're in consults with them, they really never think to ask, but they should know this answer?
Yeah, I would want to know what their approach is for the mid face. Are they going into the deep plane? Would there be fat grafting involved, and how much fat grafting? Because again, there's never any one right technique. But I would want to know how much are you relying on fat grafting because we know that that can be frankly unreliable. Um, I'd like to know how they're planning to advance and suspend the mid face. I'm, for instance, as a surgeon, I'm not a huge fan of cable sutures. That's where you sort of run a stitch from this area and you sew it way over here. So there's a spanning stitch in between. Usually, if we want reliable work done, you put a stitch in and you tie a knot, kind of like you tie your shoe, and you expect it to advance, and the knot's right there. And we believe that we have better luck with that kind of suturing than with cable sutures. So, yeah, I would want to know a few of those.
Okay. Perfect. Can you just explain endoscopic facelifts for our community?
Yeah, it's really a very innovative area, and it is on the rise. Everybody's talking about it. Everybody wants to learn about it. Essentially, we're starting to figure out ways to get down into the mid face here, or way up near the brow, with the brow inside the hairline incision, and do a pretty good job of lifting the mid face and getting it to stay there. We then, once that's done, as I mentioned a minute ago, we can come from behind the ear with the scope and into the lower portion of the face and also free up that tissue. So um, it takes a while. It's a little bit tedious. It's arduous, but you know what? It's doable. And some of the results I'm seeing and that people are getting are very, very impressive. This area reminds me of when I was in medical school in the 90s and the laparoscopic cholecystectomy was coming out. That is a laparoscopic approach to taking out a gallbladder. That some of the old timers didn't want to learn. They kept claiming it was unsafe. There were all kinds of heated arguments at our conferences and things. I'll never forget it. And of course, as you know now, nobody would ever open up the old-fashioned way to take out a gallbladder. Why would you give the patient that big long scar? Uh, it was just a matter of getting the instrumentation right and getting the training right so that people could approach the gallbladder from a different area. And I think that the face is the exact thing, just lather, rinse, repeat. It's the whole argument all over again. There are people saying it's not safe. There are people saying it's not efficient. You're not going to be able to get a good photo. You're not going to get a realistic outcome. I think, until you've trained in it and you've experienced it for yourself, I don't really think you should be making statements like that. It's a really exciting area. And I personally am beginning to get my own training in.
And the big benefit is what's the biggest benefit of doing endoscopic?
So one of the stigmata of having a facelift is an incision around the ear, in the front of the ear. And we can completely avoid that. We can also avoid incisions near the hairline, in the brow and such. So it's almost invisible, very hard to track it down. And as I say, for the right person, we really are beginning to get very impressive outcomes.
Wow. I mean, the tech is amazing. Have you seen like the technology itself improve?
Yeah. Yeah, in a couple of different ways. It's got to do with the endoscopes themselves. Silly things that you wouldn't think matter. The type of scissor for dissecting, the spreading instruments that we have, and some of the techniques we use to not just elevate but to hold things in place. There are some ribbons and things that we're using nowadays that are very, very effective. And I personally, I think it's a big wave. There's no point in trying to fight the tide. It's coming, and so that's why I'm trying to get trained.
And what an exciting time. And I love that there are surgeons who, we're about the same age. We were trained in whatever our skill, we went to school for in the 90s. And now we're getting retrained again on the most modern technology, like me, AI, and you just these amazing tools.
Yeah, I completely agree. It's a good comparison.
Perfect. Okay. Beauty seekers, here's what you just learned. Mid-face lifts have decades of results behind it. Surgeons know what to expect at 5 years and 10 years because they've seen it. Dr. Sterry, of everything we've just discussed today, neck, brow, mid-face, what is the one area of the face where you're not ready to tell a patient that endoscopic approach will hold up long-term?
I think for the mid phase, we still don't know for sure how long the endoscopic lift is going to last. I, I don't mean disrespect to my colleagues because I have I have friends and I know people who I respect immensely who seem to get outstanding results, which is why I'm so intrigued by the area. But I'm so intrigued. I'm trying to get my training currently. But as I say, I don't think that we really have results, 10 years later. Uh, we don't have studies that proves that these techniques are going to hold up. We see results that they want to post 3 months, 6 months later. But I'd like to see some results a couple of years later. I'd like to see some comparisons, some actual science. So actually, in my mind, the jury is still out. I'm pursuing the training. I'm incredibly curious. I think it's a very exciting area, but I'm not necessarily sold on it yet.
So then just to clarify, there are studies that show longevity of endoscopic brow lift or a neck lift, just not the mid face.
Yeah, I don't think there are as many and as widespread. They don't have the same scientific power as some of the other stuff. Only because they're newish, right? We haven't really been doing them, or that many of them, for that long.
Okay, that's fair, and that's what I would want to be told if I was considering a mid-face. You know, you're kind of taking a gamble, I guess, right? It's great initial results, and we just don't know for sure if it's going to last.
Well, yeah, we don't know the longevity. I mean, look, the folks who want the endoscopic facelift, well, they're really trying to avoid the stigma of having an incision near the ear, in the front of the ear. And I absolutely understand that. I do. I Now, usually that scar is really good anyway, but I understand. And they're usually willing to accept that it may not last as long. Maybe it will. We just don't know yet.
Beauty Seekers Dr. Sterry is not yet convinced that endoscopic mid-face surgery will deliver long-term results comparable to traditional approaches. Whether the fixation holds 5 years, 10 years, the plastic surgery industry just really does not yet know. He's performing cases, he's watching it carefully, and he respects the surgeons doing it. But what I'm hearing, Dr. Sterry, is that you would not tell a patient that an endoscopic midface is proven to last the way a deep plane facelift.
Yeah, I think I'm comfortable with that. Yes, I agree.
Okay. Thank you. Dr. Sterry, you walked us through 3 areas of the face today, the neck, the midface, the brow, and we learned so much about what an endoscopic surgery is and the questions that we need to ask as beauty seekers with respect to our surgeons so that we can make the best decisions for us. That's what a true craftsman sounds like, and I appreciate your candor. Thank you for being here on Beauty Seek.
Thanks so much for having me. This was a lot of fun.
Beauty seekers, from the bottom of our hearts, thank you, not just for watching, for being part of a community that believes you deserve to know what surgical techniques work, which ones are still being proven, and what questions to ask before you book a surgery. Every subscriber is how we keep bringing you physicians like Dr. Sterry, the ones who tell you their truth. Thank you.
And when people say, I'm a cosmetic surgeon, I only do cosmetic surgery, that could be anybody. Or cosmetic surgery. And that could be anybody. That could be a dermatologist, internal medicine, OB-GYN, psychiatrist, anybody. And part of their certification is they have their own standards, but obviously they're different than what we have for plastic surgery.